Dr. Paul Schultz is an infectious disease specialist with Norton Infectious Disease Specialists. He received his medical degree and completed internal medicine residency program at the University of Louisville. He also completed a nephrology fellowship and infectious diseases fellowship at the University of Louisville. He is board certified in internal medicine and infectious diseases. And Dr. Schultz currently serves as the system epidemiologist and medical director of infection prevention and employee health for Norton Healthcare. He had me worried when he got up and left, and I'm thankful he came back. Paul,
I had to have my
welcome.
glasses in. Otherwise, I'm not credible without my glasses.
It does make you look smarter, so thank you. All right, it's yours. Thank you.
Clear lenses, yeah. And I almost finished the nephrology fellowship, quite finished. So I usually start with a joke about what topic and idea is not hot, but I'm going to instead thank Dr. Morris. He took care of my father, did an ablation for my father. It was a great experience. And we appreciate that. We know the heart's very important. Otherwise, you can't pump antibiotics around the body. See the cardiology service. Is my presentation up? I thought I'd start with this. If you're not familiar, this is the Johns Hopkins website. They had up, I was impressed with this. They had this up really early in COVID, and there was a real-time tracker. This is a snapshot, of course, but a real-time tracker of all the cases around the world, and you could watch this thing die. We had somebody that was kind of caught in the beginning, but you can see here, I took this snapshot just a couple days ago, and you can see the numbers there, pretty impressive, 55, almost 56 million global cases. You can see the hotspots around the world there on the color-coded map. And then maybe most importantly, you could see down there in the right-hand corner that orange bar graph showing the daily cases, and you can see that getting really almost exponential there. So obviously, I think we're all aware of the big picture here with COVID. You see the global deaths at over 1 million. So once in a lifetime, hopefully, situation for all of us as people on the planet and as healthcare providers. So I had a couple, just to be clear, all my references will be CDC, World Health Organization, NIH, or the Department of Defense, unless otherwise specified, like this Johns Hopkins. And I have a couple disclosures to make there, as you can see on the slide. So here's the CDC US map. This is just from a couple days ago, and the darker the color, the more intense the number, or the more dense the cases per population. You can see there where we are in Kentucky, somewhere right about in the middle. Interestingly, you see that hyper dense dark area in the central northern part of the country. Don't have a real good explanation for that. And you know, interesting also, I think that there's really hard to come up with trends for this. You know, you might look at the map and say, well, I expect this state to be a certain way, or that state to be a certain way based on whatever, but you can see here it's somewhat all over the map. And then this, I think, is probably more important. This is hospitalization. We know as a health system how critical it is in terms of resource capacities and our ability to continue functioning throughout the pandemic. And the red line there these are age related lines. So the red line is 65 and over. The next line, the darker blue, is 50 to 65, and then I believe the light blue is 18 to 50, and then you see down below the pediatric population. So clearly, if you measure severity, or I think you can correlate severity to hospitalizations, you can see that age matters, and that 65 and over population is the most impacted, followed by the 50 and to 65 population. So, and if you're a Norton healthcare provider, so that the doctor and Josh and others have done a nice job of putting out good data for us on our particular situation within Norton Healthcare and where we are in terms of numbers like this and capacities. But this is really compelling regarding how much age impacts severity of illness. So here is this is a slide from the World Health Organization. It's the 9 steps to prevent COVID infections, protecting yourself and others. One of the things that I always try to mention when I'm speaking publicly about this or even privately is to remind people that when you are doing this, you're doing that not only for yourself and others, but that others includes healthcare workers, frontline healthcare workers, and you know, we want to be respectful of those folks. That's been a challenge, I think, as time went on and people, you know, were desperate to get back to pre-COVID activities. But I always ask people to remember that you're not just taking the risk for yourself if you're going to get care, and most people do. So here's the 9 steps that we can all use to help ourselves and others. So that leads to, I think, you know, a question about, well, when do you test people? Because, you know, in the beginning of this, you know, you could argue that we didn't have much testing and there really was no need to test if you were in lockdown mode. Hopefully we won't get there again here or anywhere else, but total lockdown, I mean. The question really became, you know, when do you test somebody? So who and when? So the who here, and this is viral outpatient testing, so wanting to know if the patient has active disease. For sure, you can make a case to test anybody who's symptomatic. Not necessarily have to, but you can make the case. We sometimes refer people for testing because it's important as a provider or an employer, or for instance, as the health department, to test somebody and know whether they have active disease. Close contacts of known cases can be a population that we might want to test. And then these 2 statements I think are really critical about testing, and for sure the next statement, if you don't do it, it can really make testing or you lose the value of it, less valuable. If the person who thinks they might have the disease doesn't quarantine while they're waiting for their results, then you could have several days or longer, depending on how long it takes to get the test back, where that person can be spreading disease. So if you get to the point where you think, gee, I need to be tested, you can easily make the case that I should also be quarantined while I'm waiting for those results. And that I think is where maybe we have lost significant control of this thing. I know a lot of anecdotal situations where people told me that they were waiting on a test result, and I'm thinking, well, gee, if we get a positive on that, we're going to have a lot of contact tracing to do because they haven't been careful while they were waiting. And then I think for sure the last statement is true, and you can apply it in your practice, is that testing is not for everyone. There's many examples, you know, where you can make the case that you don't need to test because maybe a clear-cut case of COVID, and there's not any real value in knowing that. That's not different than other things that we do in our practice pre-COVID, or that that maybe, you know, and for sure in times where testing is a limited resource, maybe that testing resource could be utilized better. I hear now that lines are starting to form in testing sites around the country in anticipation of Thanksgiving, and you know, that gets tricky. Another very important, maybe the most important message here on the slide, and it's over there on that clipboard to the side, is that a negative test does not necessarily mean that you're truly negative and that you won't get sick later. And that was a really big problem in the beginning of this, when we figured out that there was a significant false negative rate. And I think the testing technology has improved significantly, but there's always the possibility that a negative test does not mean that the patient's truly negative. And then, you know, as a clinician, you have to keep that in mind. And if somebody is acting like they have COVID, a negative test doesn't necessarily mean they don't. So here, this is straight off the CDC website. I don't want to go with it. it illustrates a couple things. Number one, what to do, and as I said on the slide here, quarantine while waiting for results. This is what quarantine means. And you can see here that it's significant in the sense that you would try to prevent infecting other people. You can see the guidelines there. I put a bar here on the bottom for all the following scenarios above. Even if you test negative for COVID-19 or feel healthy, you should stay at home since symptoms may appear 2 to 14 days after exposure, right? So that's a real trick about, and not to get into the weeds of that, but depending upon the scenario, a negative test may not mean anything just because of timing. So, and this has been really, really difficult. So if I have an exposure and then maybe this is the question I've been asked the most: when do I test myself so that I know I can do what I need or want to be doing? And the answer is really tricky. It's very much dependent upon the particulars of the situation. And in a lot of cases, you may have to really know, you might have to test the person multiple times to really know, and that just isn't practical. So that kind of testing has really been challenging. And unfortunately, again, I think, we see a lot of it right now with the idea, well, I can go to Thanksgiving dinner with the family because I tested negative, a week ago. That may not be the case. So it's really difficult. And then the other thing that is important, I think, to know is that there is technically a difference between quarantine and isolation. Isolation tends to be applied to people that we know have the disease. And here are the guidelines on that. And again, when you're in isolation, you're taking even more precaution to try to make sure that you don't infect anybody else. So this is, I think, important for people to understand. And then applying it, I just took 2 slides off the CDC site because I didn't want to try and go through all the scenarios, but these are the more common scenarios. So I think, or I know I had COVID-19 and I had symptoms. And here's the CDC's statement: you can be around others after 10, this is current and it's changed, 10 days since symptoms first appeared and 24 hours with no fever without the use of anti-fever medications. And the other symptoms of COVID are improving. They put an asterisk there on the loss of taste and smell because they may persist for a long time after the disease. And then they mention here, and I think this is important too, I get asked this a lot, most people don't require testing to decide when they can be around others. So one of the things that seems to be clear now is that that repeat testing in most cases is not necessary and may even give you a false positive in the sense that there's not viable virus, but or the patient's not contagious. And then they mentioned there that these recommendations do not apply to persons with severe disease or severely weakened immune systems, and that's a population where you may shed virus for a longer period of time, and we have to be more careful. But for the average person out there, this is a common scenario. And this is what the CDC is asking us to do in terms of giving guidance to patients. So the other is I know I definitely tested positive for disease, but I didn't have any symptoms. And then they give some guidance there. They still give the 10 days. You can 10 days after the positive test. And again, they say that most people do not require testing to decide when they can be around others. And then they loop this into the previous slide. If you develop symptoms after testing positive, you kind of loop back and sometimes can get into a circular loop there. But this is another common scenario as people go out and seek testing, what you might call surveillance testing, because they don't have symptoms. They may not have even been exposed or known that they were exposed, but they want to test for whatever reason, and then you get a positive. This is the way that the CDC's recommending that we guide those folks. And again, there's other scenarios that you may encounter, and I encourage you, this is cdc.gov information. You can go there, look to see if you can find the particular situation and get some guidance, but I didn't want to go through all of them here. So obviously Thanksgiving is less than a week away, and I know that's been a common discussion and probably getting a lot of questions from patients. So I went ahead and put this up. This is from the State Health Department, Kentucky.gov. This is actually about a week or 10 days ago, maybe even October guidance, and you can see they're avoiding in-person gatherings with people you don't live with your home, recommending that you always wear face coverings and masks, things that we don't often do when we're in our home with our immediate family. We also don't tend to maintain that social distance of at least 6 feet or more. And then a couple other things here about parades and shopping. As you may know, the governor put in place more strict guidance, if you will, I think just on Monday, and basically that private gatherings must be limited to current household plus one other household and no more than 8 people total within these other guidelines. So this is the official guidance that came out on Monday from the governor. And I just wanted to make sure that everybody was aware of that. Probably people are, but I thought it was something of interest. So moving into a more clinical discussion, if you have a person who's known to have disease or suspected to have disease, strongly suspected to have disease, the World Health Organization actually put out this clinical scale early on in the pandemic, and I think it still can be applied well. So you see there the patient state on the left-hand side, and all the way from uninfected to dead, and then 3 categories in between. They describe those categories and then give a score to it. So it's a 0 to 8 score. And in an ambulatory setting, you have 2 categories: no limitation of activity and limitation of activity. That's 1 and 2. And then they have the hospitalized categories. So I thought that I might talk about treatment and or management, I guess, is basically treatment of these, some of these categories, to illustrate where we are at the moment. And this is ever changing. This week alone, we've had big changes in this with new FDA emergency use authorizations. And then I don't know if you may have seen last night, the World Health Organization putting out guidance that is direct opposition to NIH guidance, but I'll try and walk through that without getting too far into the weeds. It's an ever-changing thing, and it's complicated, I think. One thing I think to know is that the FDA did put in place this coronavirus treatment acceleration program. So we know, I'm going to talk about vaccines and warp speed, Operation Warp Speed, in a moment, but there is also a program to accelerate, not change necessarily the process from a safety and efficacy data evaluation standpoint, but speed it up. So there's this coronavirus treatment acceleration program that is underlying what we're talking about here. And then I use the NIH treatment guideline. There's an IDSA guideline and other guidelines to World Health Organization, as I mentioned, but I decided to go with the NIH because I thought it fit into this clinical scale a little bit better, maybe. But so right off the bat, there is insufficient data regarding to make recommendations regarding convalescent plasma, SARS-CoV-2 immune globulins. So, and we'll talk a little bit more specifically about that because that changed. IL-1 inhibitors, interferon, vitamin C, vitamin D, and zinc. So this again is a little bit off because things changing so rapidly. But there's a lot of discussion about, well, what do I do with? And these are things that have been tried. It doesn't mean that they don't have some utility because you start to get into the weeds of definitions and things. So for instance, with convalescent plasma, we have a program in our hospitals and some people are getting convalescent plasma, and there's even EUA status or granted by the FDA on that. And then some of these other things are similar. The COVID immune globulins. So there was actually recommendations against from the NIH on these things. Hydroxychloroquine with or without azithromycin, lopinavir, ritonavir, which is an old HIV medication, ivermectin, a couple other things that were more commonly used because they were fairly easy to use. IVIG, tocilizumab was very popular around the country and world at one point in terms of a possibility. These Bruton's tyrosine kinase inhibitors and Janus kinase inhibitors. I'm going to speak specifically about baricitinib. I think that's the correct way you say that. but anyway, you can see here where a list of things where they say there's insufficient data, and this is as of a couple days ago, recommend against. And then some things, Remdesivir, well, actually I said some things. One thing that's FDA approved, Remdesivir. First FDA approved COVID treatment, it's a direct antiviral. This is recommended in a what would be a WHO clinical score 5 to 6. You can see I selected that out of the previous slide and put that down below. So hospitalized severe disease, you can see there that's score 5, 6, and 7 from non-invasive ventilation and or high flow or high flow oxygen up to ventilation with additional support. So this is really a drug for hospitalized patients at the moment, and that somewhat makes sense because it's also a infusion drug, so it'd be a little trickier to give on an outpatient basis for an acute disease. But anyway, this is where Remdesivir sits at the moment. As I mentioned, just to illustrate maybe the difficulty here in terms of data and recommendations, the World Health Organization came out either late last night or early this morning and recommended against using Remdesivir. So it gets really tricky, and it changes on a moment's notice, as it did last night. Bamlanivimab, this is one of the monoclonal antibodies directed at the SARS-CoV-2. As I mentioned in the previous slide, this was a different status up until recently, and I highlighted their emergency use authorization, and I highlighted unapproved because there is a difference between EUA and FDA approved, and that's, I think, important to know, and I'll explain a little bit of the details of that here in a moment. But I highlighted this one too because it is something that is EUA for ambulatory use, and you can see those categories in terms of severity are the no limitation of activities and the limitation of activities, that 1 and 2 class, but it's an ambulatory treatment possibility, in this case for people 12 years of age and older, or at least weigh 40 kilos. And then they specify people who are at high risk for progressing to severe COVID-19 and or hospitalization. So the idea here is to treat early to prevent that decline. And what they define as high risk is anyone with a BMI 35 or higher, chronic kidney disease, diabetes, immunosuppressive disease, not otherwise specified, currently receiving immunosuppressive disease, also not otherwise specified, greater than or equal to 65 years of age, or 55 years of age and older, and have cardiovascular disease, hypertension, COPD, or other chronic respiratory disease. And then in that pediatric, technically population 12 to 17 years of age, they specify a BMI in the 85th percentile or higher for their age, gender, sickle cell disease, congenital or acquired heart disease, neurodevelopmental disorders, medically related technology dependence, and then asthma and COPD that requires daily treatment. Now, this is really important because what the FDA expects when you are treating somebody using an EUA or under an EUA authorization is that you follow this guidance. And then in addition, oops, I'm sorry. I think I got my slide a little ahead of myself. In addition, they also expect that you will communicate to the patient or the patient's caregiver in a case of a pediatric patient or somebody who can't understand for themselves, that this is not an approved therapy, fully approved, but an emergency use authorization. And also that you document in the record that you've given the patient the fact sheet, inform them to alternatives, and that it is it's not an approved drug. So that's makes it a lot different than an approved drug in which you don't have to do any of those kind of things, even if you're using it technically off-label, which we do sometimes with FDA approved drugs. So there's basically what that means that the FDA expects us to do a lot more in terms of informing and documenting when we're using an EUA product. When Remdesivir first came out, and we had a team that was doing this in the hospital, helping the providers that wanted to treat their patient get through this EUA process. The other thing that you see there is that you're supposed to submit an adverse event report to the FDA through their MedWatch program within 7 days of onset if you do decide to treat somebody with an EUA product. So this is a lot, and we don't typically. It's very rare, I think, pre-COVID that as providers we would be in this situation, but here in the COVID world, we've been doing this quite a bit, and it's a lot of expectation from the FDA. So that EUA really means something in terms of how you treat the patient. So another one, this just came out, I believe, last night. Baricitinib, again, I think I'm saying that correctly. That jumping around here, but that's in that Janus kinase inhibitor category, was given EUA in combination with Remdesivir. So again, this is going to be for hospitalized patients in that mild to severe category 3 through 7, and it does have to be in combination in order to match the FDA emergency use authorization, and all these other things apply. Sorry, I'm jumping around there, but all these things that I mentioned already apply to that scenario as well. So again, it's a different than the FDA saying this is an approved treatment. And again, the only approved treatment right now is Remdesivir. So in terms of WHO clinical score 3 and below, other than the bamlanivimab, I'm blowing that, bamlanivimab, I'm sorry, you have really no treatment that is recommended or I'm sorry, approved or on EUA right now. No specific antiviral or immunotherapy is recommended. And actually, they make a statement in the NIH treatment guideline that they recommend against the use of dexamethasone. So I've been asked a lot about positive people on an outpatient basis. What's out there that has any data supporting it or guidelines supporting it. And right now, this is where we are, unfortunately. Other than the bamlanivimab that I mentioned is EUA and requires a significant amount of work to get treated. Now, if you're a Norton Healthcare provider, there is a process in the works to get this set up, is my understanding. Maybe Dr. Honecker can make a comment about that when I'm finished. But I just want to make sure everybody understood what that meant. So next topic, I thought people would probably be interested in was the Operation Warp Speed, the accelerated vaccine process. So just like the accelerated process for treatments, there was this accelerated vaccine process. The mission was to deliver 300 million doses of safe and effective vaccine by January 1 of 2021. Obviously, that goal is not going to be met, but there has been significant progress. That 300 million could be changed to maybe 20, 40 million. I'm not sure exactly where it'll be, but there may be doses of what the FDA considers to be safe and effective vaccine available by January under probably emergency use authorization status. You can see here on the next bar, the typical process, and it's a 73-month to completion. And the goal here was to accelerate that to about 14 months. And you can see each section along the way, what they were doing to try to make that happen. Everything from in the beginning, creating vaccine candidates once the viral genome sequence was available, to using other vaccine platforms that were developed for other vaccines. I'll talk about that in a moment. Then maybe most importantly, taking that typical 42-month process in the second stage and getting it to 6 months. So here they getting large-scale phase 3 trials with tens of thousands of volunteers going, and at the same time starting the process of manufacturing if it looked like there was a promising candidate, so that you were risking manufacturing product that wouldn't make it through that phase 3. But if it did make it, you would already have that manufacturing going and be ready to already working on distribution. And you can see that they describe that tiered approach in the next box, and then the box 4 and 3. So the idea then would be also to get the review that usually is 12 months done much quicker, and bottom line, get that 73 months to 14 months. This next slide illustrates that. You see here trials and manufacturing up in that upper left-hand corner going on at the same time, which was the biggest reason why I wanted to show this slide. You know, it illustrates everything that's happening all essentially stacked on top of each other, so that you can get to distribution and immunization much quicker than we typically would. And this is the World Health Organization's program around this similar concept. And you can see in maybe a better visual how they took that traditional vaccine development timeline and stacked it so that you could get there a lot quicker. Still following in phase 4 for the appropriate length of time, but getting everything else stacked on top of each other so that you could be there faster in phase 4. And again, a lot of it is just making sure that you're working on infrastructure, manufacturing, approval, and those sort, or I'm sorry, infrastructure and manufacturing ahead of approval, so that if there is approval, you're ready to distribute. So in terms of the specifics in vaccines, as of early October, there was 42 candidates in clinical evaluation, of which 10 were in phase 3, and of course that's almost 6 weeks ago now. Another 151 candidates in preclinical evaluation. Typically, a phase 3 trial would require 30,000 or more participants. If you've been following the the Moderna and Pfizer announcements, you know that they were over that 30,000 threshold. And all of the top candidate vaccines are for IM injection. Most were designed for a 2-dose recommended dosing schedule, but the 2 with asterisks there on the chart that happen to be viral vector vaccines, the University of Oxford AstraZeneca, which most people know the AstraZeneca, and then the, I'm sorry, there was more than 2, blocked myself here. And then Gamaleya, their research institute, and the Janssen, all viral vectors. 2 of those, and they should include the Janssen here with an asterisk because there is a single dose trial in place, are unique. So obviously in terms of getting immunity faster, the 1 dose has an advantage. So they also show here that the Moderna and the Pfizer BioNTech are RNA vaccines. And there's been a lot of discussion about that. And in this next slide, I tried to just illustrate that quickly. So the mRNA vaccine is essentially a new technology where they inject an mRNA that is designed to produce the spike protein for the COVID-19 virus. You inject that, the vaccine triggers production of the spike protein and antibodies specific to it, and that confers immunity. And as we heard, at least on a high level, they seem to have succeeded with that, Moderna and Pfizer, with this new technology. Now, one of the things you may have heard about this new technology is that the unfortunate part of that is it's 2-dose vaccine and it requires refrigeration to minus 80 degrees Celsius. So that makes distribution less easy. But again, all of that is infrastructure is being put in place to try and get that out as quickly as possible. And then this is the viral vector vaccine, the other technology that is has 2 companies close behind in the Operation Warp Speed. And so what they do here is they take a replicating vector, insert the coronavirus spike gene, create a non-replicating viral vector, and then inject that into the person and get the body to produce the coronavirus spike peptide that hopefully is going to generate the immune response and the antibody. The advantage of the 2 products, I'm particularly familiar with the Janssen product, viral vector product, is that you can potentially get to a 1 dose and these products don't require the same level of refrigeration, so that allows them to be more easily distributed, hopefully. So we may see a tiered distribution system where the mRNA vaccines that require the bigger or more difficult infrastructure, if you will, have less sites where you can actually get immunized, and maybe even be prioritized for frontline healthcare workers and other people who can't distance themselves from people in order to help people, and then maybe a second tier where you can get more wider spread distribution of a vaccine like these viral vector vaccines. But that remains to be seen. You may have heard that the FDA plans to meet and discuss this all here in a couple of weeks, and so we'll probably start hearing more about that soon. The reason I'm much more familiar with the Janssen viral vector vaccine is because we are actually participating in the trial. This, if you're interested, you can go to Stop COVID Kentucky. Their trial is called the Ensemble Trial, and we're partnered with UK Baptist Lexington on this, and have really been grateful for the experience, and we're glad to bring that opportunity to the Louisville community. As far as I know, it's the only active vaccine trial in Louisville, and if you're interested, go to Stop COVID Kentucky. I don't know where I am on time, Josh, but actually that was my, second to last slide. I thought this was appropriate statement. It's sometimes attributed to John Lennon. I don't know if that's true or not. I just put unknown because I didn't know. Everything will be okay in the end. If it's not okay, it's not the end. I hope everybody is still hanging in there and can see some light at the end of the tunnel with some of these treatments and vaccine that are starting to get FDA EUA status and approval, and we should have that with a vaccine soon. So with that, I'll turn it back to Dr. Honaker.
Thank you, Paul. Appreciate that. And we have the most questions, I believe, that have come in today from your talk, which we expected that.
That's because of me, I'm sure. Yeah.
It's because of you and the hot topic of COVID. I do want to take a moment to personally thank you, Paul, for your leadership, all the hours. This has been a trying many months for everyone, but given you and your role as a system epidemiologist, I know you've been on the forefront of many decisions around policies, procedures, answering questions night and day. So thank you. Thank you.
I appreciate that, Josh. Thank you. Yeah.
And I know everyone here feels the same way as you've been a leader for a long way time on this area. Let's go to some questions, Paul. I'm going to start with the first one, and I'm just going to walk through them from the earliest one to the current last one. Says, what is your opinion about the recent Danish study that found non-N95 mask that did not protect the wearer?
I'll have to say that I'm not extremely familiar with that. There's been a lot of debate I know about masks, and I'm going to go back. I meant to pull up my deck here so that I could go to particular slides. So I'm going to go back to this, and my take on that is similar to sometimes when I get in a discussion about a vaccine that doesn't have high efficacy, and we're in a discussion about that, and I say, well, my opinion is that we should do what we can do, and I think that is somewhat of a controversial topic, maybe like now even Remdesivir, and so for that reason, I haven't changed my recommendation for people that they use masks as much as they possibly can to try to prevent the transmission.
Yeah, I think that's a good philosophical point. We're in a place where we all need to do everything we can, even if it is a small impact in small ways. Yeah. Next question, Paul. From a time check standpoint, we have about 10 minutes left.
Okay, perfect.
So we can get through a number of these questions. Why are Preop, the PAT patients, told they do not have to quarantine until results return?
That's a good question. And that would be, if you go into this slide here, I think you can still see maybe. That's a situation I think you could get away from the quarantining testing, because presumably you are somebody who is deemed ready for surgery, or you're going to be deemed ready for surgery if you don't have a positive test. The presumption there, I think, is that the likelihood of a positive, and of course this could change, right? Because there, as you probably know, we've had times where we had a lot of transmission in the community and times where we had not as much. But in times where we haven't had as much, I think you can easily make the case that you don't need to quarantine. But in times right now, maybe that, that's something that we need to look at. I'm not, I assume that's a comment directed at our policy. Josh, where we are on that as an organization?
Yeah, I would just add that my understanding is the recommendation for folks getting PAT testing for the time that you're waiting for your test results and all the way up to the time of your surgery. Obviously, it's best if you're negative going that surgery because we know you're more likely going to do better. It's not just about exposing people from being positive. It's about you doing well as a patient. So, philosophically, I think one can make a great case that it's wise and a good recommendation from clinician to patient to be quarantined as much as possible from the time you get that test and you're up to your point of surgery, just for your own sake, and because you never know about your exposure. So that's my thought.
No, that's a good point as well, and it goes back to something I said earlier about showing up at Thanksgiving. The test is only as good as the time before the test.
Yeah.
Yeah.
Time is key. Oh, let's go to the next one. For the 6 feet definition of a close contact, does it matter if you're wearing a mask?
So the CDC guidance, I think, on that has changed over the last 6 to 9 months. And the way I understand it currently is that, and this, gets maybe into this whole mask debate, which I, don't know that we want to go into, but that if you have been within 6 feet for more than 15 minutes and even masked, they are considering that a potential exposure. So, I think that it does matter. But again, going back to the previous question, I think what you end up debating is how much does it matter? And hopefully we won't find out that the answer is it didn't matter at all. We may know that, maybe down the road. But for now, I think it's best if you not only mask, but also try to keep the 6 feet distance if you can. If you can't, you can't.
Yeah, and this comes back to our employee health team. As you know, as you work closely with them, you have all these unique scenarios every day you have to work through to decide whether a true exposure and whatnot. But obviously, mask and 6 feet as much as possible. Next question. Do you have any insight on the question of how blood type may play a role on test results and severity of the system?
I don't. I know that that's been also a topic of discussion, and it's just like it has been in our house. I happen to be O negative, so it seems like I've been on the right side of that if that ends up being a thing. But I don't know if there's enough data for us to really say anything definitive on that, and I certainly wouldn't rely on it. I'm not relying on that to protect me for sure.
Okay. Next question. It's kind of a long question, so I'll read it slowly here. Dr. Schultz, as you remarked that testing negative does not equate to not having COVID, how does that apply to us in healthcare where we're trying to balance the need to protect our patients and colleagues by furloughing versus a negative test?
I'm not sure this is exactly the question, but I think maybe that in there is a question about a testing strategy versus a time strategy in terms of furloughing and exposures. And as you might know, whoever asked the question, that's changed over the last, during the pandemic. I think the trick on a testing strategy is exactly what we talked about a couple other times, is what about the time since the test was taken? What's happened since then? And often there's enough time and enough activity since the test, especially in a frontline healthcare worker situation, that the testing can lose its utility. But I think those cases are often best handled anecdotally or on a case-by-case basis, and that gets difficult as well if you're trying to manage a lot of cases. So I'm not sure if that answered the question, but
well, and Paul, on that note, this scenario came up for me this morning. Someone was asking about an employer and a workplace, and it was that, in the event that someone's exposed to someone else and they quickly go get a test showing they're negative, well, that just doesn't have much utility.
Yeah.
Because if they're not a few days out, they're not symptomatic, I can bet you that test is going to be negative. So that's what I fear happens so much in society, is we have early tests because people had exposures and they have a negative test and they have a lot of confidence
Right.
versus the timing of the test was not appropriate to really answer the question about exposure. So
Right. That's, yeah, that false sense of security. I agree.
yep.
And so a lot of times where we've landed on that, if we were going to use testing in that scenario, that is about 3 to 5 days, but that still doesn't tell you with 100% certainty for sure, because you might not develop disease and be positive for another 5, sometimes more days. But so that's where you almost would have to test the person every day, and it just isn't practical.
Yeah. Well, and to follow up the next question that the same person had with that test, since Dr. Dave, he said, I assume that's one place where we have to have faith in the negative COVID swab and we go back to work with a surgical mask. And he's asking that's correct. And I think it is.
Well, one of the things I think you're balancing there is what is it that you're doing, and how important is it, right? Like, so again, if in some scenarios, if it's very easy for the person not to be around anybody, then we would want them to be quarantined after an exposure, or even if they just went to get a test. But if there's somebody that's really critically important, and we heard in the news recently, not here necessarily, but somewhere in the U.S., I think they were so depleted of frontline healthcare workers, they had them working with positive tests.
Yep.
Is what I've heard on the news. Yeah.
I think it highlights that whether you're always looking at capacity of your workers and capacity of your supplies, how you make your decisions. The ideal world would be, as you said, test everybody every day and stay away from everybody for 100 days. But we know that's not practically how we live. We don't always have enough tests. We can't do that. And we may not even have enough workers. So this has been a moving target. And this kind of goes with the next question, Paul. We've got really time for one more, if you don't mind.
No, I'm good. Yeah.
Okay. The first part of this question says, why is the recommendation for positive patients to return to work? Why is it 10 days after symptoms and not 14 days?
And this is a CDC question. Obviously, I'm not on the committee that makes these recommendations, as you might know, and I just don't know the answer. It's changed, I know, and it's been frustrating that it's changed. Unless something's changed since I put this slide together, which is, I was trying to do it so it would be up to date. The current recommendation is 10 days after that positive test. And I don't know that I have the answer to the question.
Okay. I know we're at time, and usually I'm a stickler on time, but I'm going to try to get to a couple test questions real quickly, if you don't mind, Paul.
No, yeah, I don't, whatever it's your gig.
Well, I assume people can fall off as they want. We've still got 214 strong. How many Norton patients have died from COVID?
I do not know the answer to that question. Maybe you do. I hadn't tracked that really, honestly.
I don't, but the times that I've heard that someone passed, it's been few, and it's been less than I thought. But I haven't heard a running number, and that's not being evasive. I literally just don't know. Yeah. But I do not know. I thought you would know that.
No, I'm sorry. I hadn't, honestly, it just hadn't been one of the, for a long time we hadn't thought about it. And I think, as you stated, it has been, the death rate had slowed, hopefully because we were providing better care with, some of these things that I mentioned in terms of treatments and other things, lessons learned as we went along.
Definitely. Well, here's another one, and this is a really good one. Can a person who has tested positive for COVID become infected again?
So there have been reported cases, and we may actually, I just got asked about a case this morning in which it looks like we may have a secondary infection here in one of our hospitalized patients. There was this, I don't have it in here, but there is some guidance. I took out some of the specifics just because it's real easy to get into the weeds, but on that, if you can see my screen, the 5th bullet point, most people do not require testing, and there's language in the CDC guidance around repeat testing that imply that they think 3 months is the time period. So that if you test positive 3 months after your initial test, for sure, if you're symptomatic, then I believe, I don't want to say this with definition, but they imply that is likely to represent reinfection. And we actually have a case here today that looks like it could be reinfection in one of our hospitalized patients. And I know, for instance, one of my colleagues in Lexington have one, and there have been other reports. So it appears that it can happen, but it's not common.
Okay, here's another one. Can using monoclonal antibody rather than polyclonal antibody cause viral resistance through mutation and potentially make a vaccine not effective?
So I don't know that we know. There seems to be, generally speaking, we tend to, think that we're going to do better with a monoclonal antibody that's directed at whatever we think we need to direct it at. Maybe this gets into the question of, is there going to be antigenic drift like we see in influenza, and then that might make a monoclonal antibody less effective or not effective at all, just like a vaccine. I don't know that I would expect that to come from monoclonal antibody treatment, but it could. I guess we'll just have to see how that evolves. That is one of the big, huge question marks right now. Even when Pfizer or Moderna, or I'm hoping Janssen and AstraZeneca and so on report good data, if there's antigenic drift, that data may go right out the window, so to speak.
Okay. Any clarity on how long antibodies should last?
That's another thing that we're going to have to learn as we go along, and that's a big question mark around vaccine durability, and hopefully it's going to be long.
Okay. Can you comment on how vaccination will be addressed for pregnant or breastfeeding healthcare workers?
So that I can't say anything specific. That'll be something that we'll wait to see what the FDA says, and I think it's going to be difficult because as you can imagine, as far as I know, none of the trials, and I'm trying to get there to the page, none of the trials involve pregnant or breastfeeding women. I can't imagine that's not the case right now. So that's going to be tricky.
All right. Why does employee health not recommend quarantine for healthcare workers who are household contacts of COVID positive members?
I assume that's speaking of our employee health. I'm going to go back to, I had I think I took it out, but I had a slide that illustrated, it was a calendar. And if you're interested, you go to the CDC website, but right after this type of scenario that they give, they actually give calendars where you can take a look and see how you might handle a situation. But it gets really difficult if you're saying caregiver and quarantine in the same sentence. It gets really challenging because it's hard to accomplish one and the other. But I don't know, we'd probably have to see the specifics of that scenario to answer the question.
Okay. Let's see. There are millions of people in the U.S. that believe COVID is a hoax. What do you say to those people?
So I've been asked about that a lot. I always wonder what the definition of hoax is there, not to be too evasive or evasive at all, but if somebody says, well, I don't even think that this virus is real and it's made up, obviously I can't even have that conversation. I don't think it's really difficult, but if somebody has the idea that maybe the restrictions and other things that are being put in place might be overly or unnecessary, maybe overly aggressive or unnecessary, I think that's an opportunity to have a discussion. And what I always try to work the discussion around to is what I said earlier, that whatever the capacities are of the health system, if you're going to get care, if you get COVID, in other words, if you're not going to just say I'll go down with my own ship, please keep in mind that there's a healthcare worker going along with you, and that I hope will cause people to get out of that idea that this is a hoax.
Okay, I have one more question, Paul, and then we'll wrap it up. So the person says, I have a patient who works for a large factory in Louisville who was COVID positive mid-October. He isolated for a total of 14 days. His employer will not allow him to return to work until he has a negative test. He will have his third test this week. How do I advise him? What can he do with an employer who is requiring repeat testing?
So we get asked a lot about these kind of situations, and right off the bat, I always tell people, unfortunately, we don't set policy for other employers, whether that's me who does some of that work with Norton Healthcare, or when I'm working just as an individual provider for an individual patient. So that, unfortunately, is really difficult. If an employer has a policy that may not be well founded in guidelines, then it gets tricky. But But what I might advise the employer or the patient and employee to do is maybe just provide some of the guidance that the CDC has out there. And you can see in 2 of these slides, most people do not require testing to decide if they can be around others. And that gets into this whole discussion about, is it viable virus? If you keep testing positive after a certain time, it's pretty well understood now, I think, that at some point, overwhelmingly, most likely, that's not viable virus and the person's not going to infect anybody, even though the test may be positive.
Right. Paul, thank you so much, and
Yeah.
appreciate your patience and taking those extra questions and being with us today.